I'm Laurie Sen from BC Cancer in Vancouver, Canada, and I'm here today with my colleague, Dr. Jennifer Brown. Dr. Brown is the director of the CLL Center, the Division of Hematologic Malignancies at the Dana-Farber Cancer Institute, and the Worthington and Margaret Collette Professor of Medicine in the field of hematologic oncology at Harvard Medical School in Boston, Massachusetts. She has a very active clinical and translational research program in CLL. Her research interests have been largely the development of novel targeted therapies for CLL as well as CLL genomics, and she has greatly contributed to much of the ongoing advancement in the management of CLL, and she's now published more than 335 papers on the topic. So an absolute pleasure to be having this conversation with you today. The thing we want to talk about is in relapsed refractory CLL, what are your key takeaways on the head-to-head trials that have examined head-to-head the different BTK inhibitors that we have available?
Right, well, we're fortunate to have a trial that compared acalabrutinib to ibrutinib directly and another trial that compared zanubrutinib to ibrutinib directly. And both of them showed that acalabrutinib and zanubrutinib were better tolerated than ibrutinib, clearly, with fewer cardiac side effects. And the zanubrutinib trial also showed that efficacy was improved compared to ibrutinib. So based on these data, I really don't use ibrutinib ever, and I don't envision going back to using ibrutinib ever.
So I completely agree with you. I mean, I think what we learned from the ELEVATE-RR trial is that the second generation BTK inhibitors really had a better toxicity profile, particularly with respect to cardiac toxicity. And then from the ALPINE trial, not only did it confirm the better toxicity profile, but there was also this question of possible increased benefit, at least with zanubrutinib over ibrutinib. But I think all of that data has really served to ingrain the current practice, and that is, even in Canada, all clinicians have really moved away from ibrutinib and are relying on the second generation BTKIs. We're fortunate to have universal funding for both acalabrutinib and zanubrutinib, and I'd have to say they're pretty much used interchangeably in Canada. I think which drug you might use is probably more driven by physician preference and habit than any true comparative data we have between the two, because we don't have comparative data between the two second generation inhibitors.
So I do agree with that. One does have to pick which drug one will use. And based on the ALPINE data, I did decide to start using zanubrutinib single agent mostly. And that's because if you look at the separate data sets for each drug, we do have one that shows improved efficacy for zanubrutinib compared to ibrutinib, which we don't have that data for acalabrutinib. It showed equivalent. Now, we don't know what would have happened if they'd done the same trial that the other one did. But nonetheless, we do have some superiority data for zanubrutinib. So I do tend to use zanubrutinib single agent. But I'm also using a lot of combinations, and I tend to use acalabrutinib for that because that's where we have the data for the combinations.
So it is getting more complicated to figure out what to do with patients in the relapse refractory setting. How would you summarize how you're sequencing agents right now today in practice?
Right. Well, so, obviously, if you start with a BTK inhibitor, then you may likely switch to venetoclax, or if you start with a venetoclax-based regimen, you might likely switch to a BTK inhibitor. But it's a little bit more complicated than that, because if you use a time-limited regimen, you can potentially repeat it. So if a patient gets venetoclax and obinutuzumab and has a very nice long duration of remission, then I'd be inclined to repeat that. And so you may say, well, what is the cutoff for long duration of remission? I think the absolute shortest where I might consider repeating is about 2 years, maybe more like 3. But if you're getting down to the point where you get less than 2 years out of it, then they may not be benefiting so much from the time-limited mechanism. And I do think that tends to happen over time for patients, and that may be a point where you start to consider continuous therapy.
I think that's quite similar to our practice in Canada. I mean, right now, if patients are getting a BTK inhibitor and they start to progress through it, they generally will move on to a venetoclax-based regimen. Typically, venetoclax and rituximab is what we have funded in the relapse refractory setting. Alternatively, if they start with venetoclax and obinutuzumab up front, we actually haven't had that available that long, so I can honestly say I haven't had anybody who's yet progressed through it, but I would say that If they've had very, very long benefit, and probably long benefit defined as at least 2 years, I probably would consider maybe going back to a venetoclax-based finite regimen. But short of a prolonged benefit, we likely move on to a BTK inhibitor next for those patients. We don't actually have funded the combination up front of BTKI and BCL2I, so we haven't had to decide what next. But I think there's a real question for me, sort of, what to do once you've used both those agents up front. And I think by the time I need to make that choice in my own practice, I am sure that there'll be much more data available, both through the trials we have and even real-world experience in other places.
An interesting problem is that in some level it makes more sense to use, say, Ven/Oben first and then go to BTK venetoclax later, right? Because then you're adding another highly effective mechanism. But that's not how the drugs are going to be approved, because all the registration trials for BTK BCL2 have been frontline. So maybe you can do venetoclax obinutuzumab after that, time limited, probably. But we don't have that data.
I agree. So what new agents are you most excited about moving forward in CLL?
Well, the BTK degraders look very interesting, I think. And those are drugs that have a moiety that binds to BTK and then brings in a ubiquitin ligase, so targets the BTK for destruction by the proteasome. And there are two that have reported clinical data both at EHA and at ASH in 2024. And they have remarkably similar response rates in patient populations that are pretty much all exposed to BTK and BCL2 inhibitor. So on the order of 76 to 78% response rate. The follow-up is still very short. So that is something that will obviously need to be followed. But most of the patients are still on trial, on drug. So I think that's very encouraging.
So I agree. I think the BTK degraders are looking really good. We have a real positive agents here in Canada, because once patients progress through our second generation BTK inhibitors, as well as BCL2 inhibitors, there's a real need for novel therapies. We're looking forward to hopefully getting access to non-covalent BTK inhibitors shortly, which I think will be a big step forward based on the data that we've seen with pirtobrutinib, which I know is fully available in your setting. I also think it'll be interesting to see with the ongoing trials whether or not that drug moves forward in the practice setting. But certainly, I think we're in need and really looking to the next generation of novel therapies that are going to move the field forward in CLL.
Right now we have covalent BTK inhibitors, and then we have non-covalent pirtobrutinib, and then we potentially have the BTK degraders. And so the non-covalents are being tested up front before covalents. And then there's the question of whether the degraders, if they're a little bit less likely to develop resistance, how they would be sequenced in relation to pirtobrutinib after a covalent. So I think a lot of that is going to depend on the mechanisms of resistance and what mutations tend to emerge depending on the order. And of course, we have very short follow-up still with pirtobrutinib compared to the follow-up with the covalent inhibitors. So I personally am very hesitant to move it ahead of a covalent inhibitor when we know we can get 7, 8, 9 years of benefit potentially out of a covalent inhibitor.
Yeah, well, fortunately, we'll get that answer from clinical trials, and in the meantime, there'll be more data coming forward, so this conversation will continue, and no doubt we'll be having more debates as we move forward. But thank you for joining me today. It's been a really interesting discussion.
My pleasure.